Hi, everybody. My name is Thomas Dayspring. Started off as an internist for many years, but in the 1980s, as lipid information started to expound, I became very interested in it, and I devoted serious study to the specialty of lipidology. It's amazing how I transformed from just an internist trying to do good health care to a lipidologist who could provide great lipid care, but also into a global teacher on lipids and everything. So it's been a fascinating ride for me. So it's time to get to your questions. It's amazing how many people cannot actually accurately define lipids if they're asked that. Lipids are organic molecules. That means they're mostly carbon and hydrogen atoms, some oxygen that are stuck together. But their characteristic is they are insoluble in water. Basically, lipids are waxes or oils, and everybody knows oil does not circulate in water. Try putting olive oil in a glass of water. Well, olive oil is a collection of lipids. However, lipids are also crucial for the health of organisms. Lipids like cholesterol get into cell membranes and greatly affect their function. Cholesterol can be a substrate to develop other molecules, especially hormones and bile acids. Triglycerides, a commonly known lipid, is actually the energy of life. It brings fat to cells, which can oxidize them for energy. So that's what lipids are. Well, that's certainly a common question. First of all, for the audience, Lp(a) is a slightly different type of low-density lipoprotein, or LDL. And LDL is just a collection of mostly cholesterol, some triglycerides, but Lp(a) particles are like a worse LDL particle. They have other attributes that make them even more what we call atherogenic, ability to perform plaque. So if people have high Lp(a) concentrations, and we know what the normal ranges are, they are at increased risk for developing atherosclerotic complications like heart attacks and strokes. So what can a patient with high Lp(a) do? First of all, make sure you're going to a clinician who understands all of the complex ramifications of Lp(a) and is trained to deal with it. If not, there are always lipidologists in most communities. Anyway, what somebody can do, of course, is take care of all your other cardiovascular risk factors. And the first one to do is lower your LDL concentrations as much as possible. So that's the primary focus of treatment at the current time, because we don't have drugs that have been proven to reduce Lp(a) available to us. So once you control your LDL, then you look at every other risk factor you have, and you should have an extensive look. Obviously, control hypertension very aggressively. If you're a diabetic or an insulin-resistant person, get both of those metabolic abnormalities under control with lifestyle and, if needed, pharmacologic therapy. There are other things that aggravate cardiovascular disease: high uric acid, high homocysteine, and a physician can measure those, and if they're abnormal, take appropriate care to reduce them. But the most important thing is start with a healthy lifestyle. And the last thing I always tell a patient who we discover has high Lp(a) is, when you go home, call up all your first-degree relatives, ancestors that are still living, children that are genetically related to you, and make sure they get tested for Lp(a). The sooner in life we see Lp(a) is out of whack, we can take definitive measures that I just described. Boy, we're getting good questions today, and that is also a very common scenario in clinical practice. So first of all, I will tell you, PCSK9 is the one drug available to us right now that lowers both LDL particle concentration and also Lp(a). However, here's the caveat. It is not approved by the FDA to lower Lp(a), for the simple reason the manufacturers of that drug have not done a large clinical trial showing that if PCSK9 lowers Lp(a), there would be less heart attacks or strokes. So until that trial is done, you're assuming the lowering of Lp(a) by a PCSK9 inhibitor works. Now, we do know they have the ability to reduce it about 25 to 30%. The primary focus in treating people with high Lp(a) now is to get ApoB, LDL metrics such as LDL cholesterol or non-HDL cholesterol to goal. But now let's get to the primary recommendation. Take a statin, because we know even in people with Lp(a), statins do reduce clinical events, even though they do nothing to Lp(a). But yet, in a small section of Lp(a) patients, taking a statin does raise Lp(a) mass or Lp(a) particle concentration, and that terrifies some people. And the elevation in those LDL metrics can be 5, 10, 15, even 20, 30%. So that worries people. But here's what you have to know. If you have high Lp(a), a small section of your LDL particles do contain apoprotein A. But the reality is Lp(a) is a minority LDL particle. So if I take somebody and give them a statin, it may raise the minority Lp(a) particle X amount, 10, 20%, but it lowers the regular LDL particles by 30, 40, 50%. So even though your Lp(a) particle concentration goes up a trivial amount, you are drastically reducing the number of LDL particles that do not contain ApoA, and that is why statins reduce events in people with Lp(a), no matter what the statin does to the Lp(a) concentration. Bottom line, don't believe the internet. Don't be afraid to take a statin if you have high Lp(a). Statins are the initial primary therapeutic agent that guidelines and experts advise us to use in people with high Lp(a). Boy, oh boy, the questions get better with each one. And that is also another real-world common dilemma. So a patient comes in, they undergo the proper lipid testing, their lipid panel, they get a good cardiovascular risk assessment, and Lp(a) is high. And they know, geez, I've led a pretty healthy lifestyle. You've checked my lipid profile and the rest of the lipids look pretty good. I don't have high blood pressure. Do I really have to worry about my Lp(a)? Here's the data. I think it was the Copenhagen study that looked at a whole bunch, it was like 12,000 people with high Lp(a) and tried to look at what is the risk. And in general, looking at cardiovascular mortality, the hazard ratio was 1.5. That means there's a 50% increase in risk comparing the people with very high Lp(a) to those with no Lp(a) abnormalities. They also looked at total mortality, and there was a 1.2 hazard ratio. So aside from cardiovascular disease, there was a 20% increase in all-cause mortality. So that should be enough to scare anybody, even though they're leading a great lifestyle, to still worry about their Lp(a). And in a discussion with their physician, see, is pharmacologic modulation necessary? All right, now we're going to get into some pharmacology here. So the drugs just mentioned are grouped under what are called PCSK9 inhibitors. And there are 3 of them on the market. The 2, alirocumab and evolocumab, are injectable, what's called monoclonal antibodies. They bind to the PCSK9 molecule and inhibit it. Inclisiran is the newer member of that family, but inclisiran is not an antibody. It's siRNA, small interfering RNA drug. That means it travels into the liver cell, and it goes to the nucleus, and by altering RNA, stops the production of the protein called PCSK9. So the monoclonal antibodies bind to PCSK9 and inhibit it, siRNA drugs like inclisiran stop the production of PCSK9. But I should have started this question by telling the audience, what the heck is PCSK9? Well, it's a protein that's in the enzyme family, and it's involved with the destruction, catabolism of our LDL receptors. Now, LDL receptors is a protein that liver cells make. The LDL receptor goes to the surface of the liver that interacts with plasma, and the LDL receptor grabs LDL or ApoB particles as they pass by, and it pulls them into the liver where they can be destroyed. So that's called ApoB LDL clearance, and that is very desirable for people who have high LDL metrics. But when the LDL receptor pulls the LDL particle in, the LDL receptor can break free and go right back to the surface and repeat that wonderful function if it is not also destructed. And the protein that diverts LDL receptors to destruction is PCSK9. So you could see too much PCSK9, you won't have LDL receptors. Your LDL cholesterol and ApoB will be through the roof. That's one of the causes of familial hypercholesterolemia. But if you have low levels of PCSK9, there are some genetic miracles who inherited the gene that doesn't make much PCSK9, and they go through life with very low LDL and ApoB levels because they have a lot of LDL receptors that can keep living. Don't you wish you had inherited that gene? Most of us have not. By the way, those people go through life with extremely low LDL cholesterol and ApoB levels and have no consequences of the low cholesterol, but also do not get heart disease. Another great question and another common scenario in clinical practice. So if, again, somebody with Lp(a) comes in and says, really, I'm not worried about this because there's no premature heart disease in my family. Well, indeed, the worst scenario is to have high Lp(a) and also have family history of either premature or heart disease at any stage of the game. So that is a worrisome thing and would make one probably be more amenable to treatments, and perhaps the doctor would get a little more aggressive in LDL lowering in such a patient. But here's the problem. That's one thing. It's good to know if there is a family history, but not having a family history of heart disease does not mean you're home free from your high Lp(a). You're always a little bit genetically different from other ancestors. Nobody has a crystal ball that can ensure your future. Some of the questions I answered previously, this quoted study showing high Lp(a) is a big risk factor for cardiovascular mortality and all-cause mortality. So you always should never assume that high Lp(a) over time is going to cause morbidity and mortality. And the therapies we have for it now, and perhaps the therapies that are coming, can significantly lower that risk. I always tell people with high either LDL or high Lp(a), if you don't want to take therapy, that is your call as a human being. But I think you're playing Russian roulette. You don't know, are there blanks or bullets in the chamber when you have a bullet like Lp(a) floating around. First of all, donating blood you're a good citizen. The world, your town, your hospitals always need blood. And we all, if possible, should do it as frequently as we can, with the permission of your physician, of course. Now, when you donate blood, whatever's in your blood is going to wind up in somebody else's body. The good news is the big worry of transfusions is promulgating infectious diseases, viruses, bacteria, other things that can be transmitted from one person to another. Lp(a) is not an infectious disease. You didn't get bit by a mosquito and get Lp(a). You didn't have intimate contact with another human being, and therefore you're getting a infectious agent. You yourself didn't get a transfusion that, hey, oh my God, that person whose blood I'm getting had high LP little a. LP little a is not transmitted through blood. You know how a person gets LP little a? They have the wrong genetic ancestors that passed on the genes that make the liver produce apo little a, and that has absolutely nothing to do with a blood transfusion. So number one, if you have high LP little a, please donate blood as often as possible. And if you have to have blood, you don't have to ask the blood bank, oh my God, did the patient who donated this have high LP little a? It's totally irrelevant. Familial hypercholesterolemia, or FH, is actually a multitude of lipid abnormalities that are typically characterized by very high levels of LDL cholesterol or ApoB, LDL particle counts, whatever you're measuring. And those are always the result of genetic abnormalities that interfere with LDL receptor production, LDL clearance through many, many different mechanisms. Now, it is genetic, and in our world today, we can identify many, many genes. The problem is there are over 20,000 genes in human beings, and nobody can have every gene analyzed, and we're still trying to discover what many of these genes do. We don't know what a lot of them do. So even all the genes that can ultimately wind up causing what we call an FH phenotype, very high LDL cholesterol in the blood, some of them are identifiable, many of them are not. Bottom line is, if your LDL, God forbid, is ever above 190, seek competent care and get on the therapies suggested by that clinician to reduce those LDL metrics. Well, boy, that is a complex question. And that really falls under the bailiwick most of the time of a cardiologist. Lipidologists are not prescribing blood thinners and beta blockers and things like that, which are all necessary after the pathology that you just described. So all I can answer is the lipid question. So are lipid drugs lifelong? For now, yes. If you qualify into the risk category that you need drugs, lipid modulating drugs, you're going to go on what is available to us today. So you're probably going to have to be on some sort of lifelong modification of lipid drugs. I will make no statement on how long you should be on blood thinners, beta blockers, and all the other wonderful drugs that are keeping people alive after acute coronary syndromes. That is the bailiwick of a cardiologist. Boy, there's a lot in that question to discuss. Number one, accelerating calcification in many cases is good. Calcification is you're just walling off the plaque with like a cement wall, and that makes the plaque unlikely to rupture, which is really what causes the clots that causes a lack of blood flow, heart attacks, and strokes. So calcification is not necessarily bad. The problem is, as you're calcifying some plaque, is there other plaque in your artery that is not calcified, that is therefore what we call, quote unquote, vulnerable and could rupture and cause the event that I just described? So increase in calcium per se is not a big worry. Statins are known to increase the calcification a little bit in arterial wall plaque, but in every trial they ever were in, statins reduce heart attacks and strokes. And that is a big problem because obviously there's a lot of pregnancies going on. Right now it is advised for a young woman, even before she thinks that, oh, it's time to start a family, that she get her health checked out, a very serious cardiometabolic evaluation, because we have plenty of data that if you do discover vascular risk factors, even early in life in a woman like that, they should be aggressively taken care of before she decides to conceive. Now, if she has lipid abnormalities that call for lipid modulating drugs, in general, they were always stopped once pregnancy occurred and then resumed down the road, either after pregnancy, if not breastfeeding, or after the breastfeeding years are completed. Therefore, a woman technically could be unprotected from a lipid disorder for 9 months during the development of the child, and for a couple of years afterwards, as long as she continues to lactate. Ideally, that would not be the best thing to do. The problem is, can we give safe drugs to such a woman? Actually, we can. For the longest time, at least for women with familial hypercholesterolemia, there's a class of drugs called bile acid sequestrants, which do not get into the human circulation. They're non-systemic drugs. They act by, when you swallow them, they bind up bile acids in the intestine, and they are excreted in the feces. If you are excreting bile acids, your liver has to use up your own cholesterol to make more bile acids. So it's a way of lowering LDL cholesterol in people. Now, they're not the most fun drugs to take. They can cause constipation. In a small minority of people, they can sometimes aggravate triglycerides, which is always a worry during pregnancy. So you'd have to be watched closely. But that is at least a safe drug that you can use. Statins for years were given the category X classification by the FDA, means not proven to be safely used in women with pregnancy. The FDA did away with that X classification system a few years ago, and they just, with statins, like with all lipid modulating drugs, it says really has not been tested in pregnancy. So you have to talk to your clinician, does the benefit outweigh the risk? The problem is it's very difficult for pharmaceutical companies to experiment with lipid modulating drugs in pregnant women. What woman is going to say, oh yeah, I'll sign on to that, give me this drug, even though you don't know what it might do to me or my child? So it's a real dilemma, and I'm not sure what's going to happen in the future other than the genetic modulation therapies that might be coming. The good news is, in many women, not treating the lipids for 9 months is usually not adversarial. Fortunately, lipid disorders take years to cause more advanced atherosclerosis and clinical events. So 9 months interruption of treatment is unlikely to be that horrific. The super serious woman could now consider statin therapy during pregnancy. As lipidologists, we've always been so worried about heart attacks and strokes. And strokes is vascular atherosclerosis that can lead to strokes. And of course, a bunch of mini strokes or any type of stroke can certainly affect cognition in some people. So what is the worry? Well, dementia, there's two types. One is the vascular dementia that's caused by atherosclerotic lesions in cerebral arteries or so. The other dementia is the Alzheimer's type, and the cause is not really known, but it's not likely that it is atherosclerotic. So I can tell you this, every preventive neurologist, and there are very few of them, they're tough to find, but these are neurologists who decided to do what lipidologists do, identify risk factors of a disease very early in life, and then modulate what you're good at modulating to prevent an endpoint. So lipidologists jump on lipids as early in life as possible, aggressively treat them with the knowledge that we will reduce atherosclerosis and atherosclerotic events, including vascular dementia. A preventive neurologist early in life, and they typically go after people who have family histories of Alzheimer's disease or cognitive impairment, or they know the genes that are associated with Alzheimer's disease have been tested in their ancestors and they have them. And there are numerous biomarkers and lifestyles that a preventative neurologist can look at early in life and start taking measures to reduce the incidence of Alzheimer's disease. The last part of this story is we know statins reduce vascular dementia. But there's plenty of meta-analyses of all of the statin trials that does show there seemed to be less Alzheimer's disease in people who take statins. Now, whether that is due to the statin's ability to lower atherogenic lipoproteins, or whether that's due to some pleiotropic, meaning non-lipid effect of the statins, is just hypothetical right now. But I think in general, if you have a family history of Alzheimer's disease, or you carry a gene for Alzheimer's disease, the one most commonly tested is the ApoE4 allele, you would be wise to have your practitioner aggressively scrutinize you for cardiovascular risk factors, including lipid abnormalities, and treat them very aggressively. All right, everybody, I wish we had more time because I love to answer lipid questions all day long, but I think the many we went through give you a lot of food for thought. I personally would like to thank so much my friends at the Family Heart Foundation for giving me this opportunity to address so many people. It is an incredible organization. You should visit their website. And also they have people who can help you if you do have the serious lipid disorders we're talking about. So it's an amazing service. Make sure you avail yourself of that. And once again, I just thank them so much for this opportunity to try and spread some knowledge on this horrific but extremely treatable disease.